political leadership and grassroots conversations are really important to find to mobilize the values that can help us collectively combat medical issues. And along those lines, let me just mention one other example that's very relevant today to our backyard. The debate over vaccines and vaccine skepticism or anti-vaccine activist, or there's a multitude of terms to try and encompass the spectrum of people who are hesitant to get vaccines. You know, that debate isn't about data. It's not about what the science is telling us. It's not about like producing more studies to convince the other side. That's a debate about values, a debate about ideologies. And if we try and understand the other side of those debates, we can sometimes find a common ground. They're not also, a skepticism of big pharma and their interest in selling vaccines that get injected into our body, that's not irrational to be skeptical of these big systems like that, or anti-authoritarianism. At the same time, we can probably find common values. We all want the best for our children. We would all want for them to be healthy and well, to go back to our initial question. So I think finding a common ground on values can address a lot of the crucial uh, issues that are facing us today. And I would just give one example, and sorry, this is the problem.
Yes, I want to echo what he says about values. I think that when we have common ground and we can come to common ground, then that creates an opportunity for the common good for all. And I think that when we talk about what I was going to say earlier, we were talking about health equity, health equality, and creating improving access for all. Making sure that there is a common ground. We're human beings, we're not perfect beings, and we're all individuals and we're different, and we will have differences of opinions, but looking at what is best for the greater good. And that does go back to what your values are and how you put um, the common good and what is in the best interest of all um, at the forefront. If we think about this pandemic, and not just the pandemic, but health disparities, equal access, access to care, and recognizing that it's like you can throw up uh, a ball of rocks, a bag of rocks, and they fall out, and everyone has the opportunity to grab some. But then understanding that everyone can does not have the same capabilities, and so when you understand that and meeting people where they are, that's the theme that I've used throughout this year, and even before. Meet people where they are. Everyone may have needs, but how you meet those needs may be different. And so when you understand that, embrace that, have the conversation so that you gain an appreciation and value what those concerns are, then that's how we can move the pendulum in the direction of improving healthcare for all, helping improve access of care as well.
Opinion, how do we create an action plan for addressing these disparities and some of the things that Professor Fisher also mentioned? And also would love to hear a little bit more from your perspective as a dentist, because I know that dental health is a significant concern, and there is significant deterioration. It's a source of pain and many other infections that stem from a deterioration of dental health that we're seeing across the state and the country, and particularly in rural areas. I know I asked you two in one.
I, well, I think that the way that we begin to address this is that we have to meet the people where they are. And I think I said that earlier. And by meeting communities, and so you can't just decide, oh, there's not healthcare in this area. Let's just go and let's set up a healthcare. Because just because you open doesn't mean that the people will come. So you have to first establish a level of trust in the community. And just because I'll use myself, for example, just because I am a doctor, I'm a dentist, and I go in a community, I may be trustworthy, but that doesn't mean that I'm going to get the trust. And I
Right.
do that by building relationships within the communities. And so I think we have to start there. And by building those relationships, you develop a level of trust, but it starts with, in building those relationships, educating the people on what is good health, what is health and wellness. And then not just giving them the education, but then understanding that community. And that's where cultural competence comes in, so that you understand what are the values and beliefs of this community. There's some, and because I'm a dentist, there in some cultures, it is that you use natural medicines. And so I'm not going to go in talking about giving prescriptions for antibiotics, but I would need to understand and be able to educate them on natural medicines that they can use. And in some other cultures, it's that my parents lost their teeth when they were young, my grandparents, and they think that's a natural progression, a natural progression. And
Right.
so educating them on that is not necessarily the case. And so once you have educated, then how do you help them identify resources and avenues so that they can? People want to be healthy. Sometimes it's a financial thing, sometimes it's a fear factor. There's several factors that come into play. And when it is a financial, being able to help to identify resources, and that's where it's so it's a multi-layer problem and challenge. But I think what I want to see us doing, the one thing that I think I have seen with the pandemic is that communities were creative in how you met the people where they were to encourage them to get tested when this first started. And now with the vaccine, every day we see, even on the news today, there's an outside concert that's going to be here in Nashville, and they're going to be giving vaccines at the concert. In some states, they're offering lotteries to get people to get the vaccine. So they're being creative, and so the creativity that has been that has evolved around healthcare and improving healthcare and improving access is something, a momentum that I hope that we will keep and can be very useful in addressing health disparities and how we change the paradigm and start to improve healthcare, particularly in rural areas and in communities of color and in those underserved areas that are disproportionately affected.
And one of the things that really stuck out for me is also that about talking about trust and your point that you can be a trustworthy person, but that doesn't necessarily mean that you have the trust. And I think that that gets to some of your work, right, Dr. Fisher? And as an
Absolutely. I couldn't have said it better. I like that. Trust is, it's, it's hard earned and easily lost. And I think the point that Dr. Farmer Dixon was making is absolutely crucial. We, a lot of times, especially in healthcare, we assume that trustworthy people will be trusted.
right.
And it has to be built up over time, which is not easy. It involves give and take. You have to give trust in order to receive trust. And that's not easy for people often in medical professions to be able to do. And it speaks to what you were saying. I keep pointing over here because you're on that side of the screen to me, uh, Dr. Farmer Dixon. And that requires some humility as well, right? To be able to listen to people and trust them, sort of understand where they're coming from and try and trust them. So I think trust is absolutely crucial. It History matters in trust.
Mm,
Uh, and a lot of times, there's this whole field of medical humanities, and most of the time, people in medicine say, "Oh, that's just." Actually, histories really matter. It matter. The syphilis trials in Tuskegee
right.
matter even today when we're rolling out public health campaigns with communities. These memories live on in so many ways. And to use an international example, the CIA, part of their hunt for Osama bin Laden, they were going around in a Hep C vaccine campaign in rural Pakistan to collect surreptitiously collecting DNA swabs from people. That has negatively affected the ability to roll out COVID vaccines in these same areas of rural Pakistan. And again, that's not, it's rational from the point of view of these Pakistanis in some way. We're bringing in this medicine from abroad, but it also underlines Dr. Farmer Dixon's point is you can't just show up in a white coat and say, trust me. It's like, or say, hey, last time, yeah, it was a ruse, but this time it's for real, so please take the shot. It's too late. The house is already burning down. You've got to build up the trust far in advance. And sorry to get on my soapbox, and this is the last thing, but that points out to something that's been in the conversation today is that all of this, what our healthcare system needs, public health, is sustained investment in stuff that's not sexy at all. Health outposts, it's having dental clinics available to people. It's having, it's all of this stuff that politicians very often find it easy to write off of a budget line when things are tight, because it's not a problem that's immediate today, tomorrow. But this is the kind of investment we need to make to have a more equitable system.
One of the reasons we have a trust deficit are that people are suspicious of one acting in their self-interest and acting out of self-interest because they are acting out of self-interest. So they assume that the other person is too. So until we can address that, we're going to have a trust deficit. And so we have to figure out, and Randall, maybe you want to chime in here. I don't want to put you on the spot, but we got to figure out how we address that. And I feel like that's a little bit too, as to what Dr. Dixon and Dr. Fisher were also saying.
Yeah, I don't mind chiming in. And I think the answer to that is we have to talk to each other. And when we talk to each other and we learn that the other one is actually serious and not necessarily just in their own self-interest, then the trust factor grows. But it has to, I think one of the doctors said, trust has to be built. It's not automatic.
Previously, it also just comes to the conversation of culture and what treatment is. Coming from a background of being Kurdish, a lot of times, like, as many people have said, dental care wasn't a common thing. And so going in constantly to get care, it was either terrifying because your first round, and like this is coming from a story from my mom, was having to get so much fixed so quickly because you never prioritized it to begin with. And that's very intimidating to go to and go to other doctors about. But on the alternative, it also just comes at like, and this is touching from a point Jackie talked about in our breakout room, is so many people go for the most expensive option of going straight to the emergency room. And yes, it might not be like, in many cases, it's an emergency, that's what they need. But also in many cases, that might not be the case. It might just be something that they don't know isn't an emergency. It's just something that they do not understand what it is. And that's the first option you hear. Because whenever you pick up the phone for a healthcare provider, your first thing, and as much as it's a liability, it's if it's emergency, call 911. And for someone who doesn't understand that, like, is this something severe or is this something I just haven't seen before? That's their immediate reaction is let's go straight there. And that puts them into this rabbit hole of, oh, if I get healthcare or if I go get care, there's so much more I have to pay for all of a sudden.
The other side of that is, we could design our health system to acknowledge that fact. Like Vanderbilt used to have a system that they don't anymore in the emergency room, where they would have nurse practitioners. So when someone showed up with something that wasn't a real emergency, the nurse practitioner could just deal with that and bill them, as a primary care visit. I don't know why they stopped doing that. Maybe they're doing it again. But it's probably easier to change our health system in some ways than that culture, But but we just demand that people, fit into this health system that we've created. So.
I think one of the things that I've seen is that I think many times there's so many assumptions that we make and that individuals in the healthcare system make when it comes to individuals and communities that are very much disproportionate. And those assumptions, I think many times is what's really holding us back in terms of how we really can provide the best quality healthcare for those individuals that are disproportionately affected by many of the disparities. One of the things that I'll keep saying it, Dr. Farmer Dixon's probably gonna get tired of me saying it, but she mentioned in our breakout, is meeting people where they're at. And I think that that's something that we have somewhat failed, at least that's what I've seen, is that we're not meeting people where we're at, and meeting people where they're at. As we all know, before we walked, we had to crawl. There's a progression of steps that has to be taken. And many times when poor people enter the ER, yes, that to them may be an emergency, but are we even at that point of access meeting those individuals where they're at? And many times I would probably argue we're not, because meeting them where they're at means pulling back those layers, going under those underlying issues to see why they chose to come to the ER, or, just many other factors and things like that. But I think we just get stuck at the assumptions of what we think individuals are or the environments they live in, and we're not willing to meet them truly where they're at and go further to those underlying issues.